Good morning, everyone. My name is John Clifton. I'm a managing partner here at Gallup, and I'd like to welcome everyone to our great hall. We're having a conference this morning on opioids and the epidemic that is plaguing the United States. You know, over the past few decades, mortality rates for kind of every population in the United States and in Europe has been declining. But in the late 1990s, there's one population in the United States where that trend flipped. And if you look at white men who have a high school diploma or less, mortality rates have been increasing. Now, one of the people that have been on the case on this is Angus Deaton. He's a Nobel laureate and also a Gallup senior scientist here. And actually, 2 months ago, he testified in front of the Senate on this issue of deaths of despair. And I want to read his quote, because he said, "We think of opioids not as a fundamental cause of the epidemic of midlife mortality and morbidity, but as an accelerant, a set of drugs that added fuel to the fire and made an already bad situation much worse." You know, not only has this trend switched, but this opioid epidemic has already led to the deaths of 33,000 Americans just in the past year. If you look at that 33,000, that's exactly the same amount of people that are killed by guns and by the same amount of people that are killed by car crashes. You could argue, and again, that data is from 2015, that opioids are killing more people than car crashes and guns. Today, we wanted to have a conference because we wanted to bring in the voice of the American people. There hasn't really been good survey research asking people how they feel about the opioid epidemic, or what they feel should be done about it, or what they feel should be done about their pain. So we did that survey, and today we're going to release the results. The person that's going to release these results is a dear colleague of mine. She and I have worked together for about a decade now. She's been all over the world helping represent the voice of the people, literally the farthest corners of the planet. She's worked on huge projects with the World Bank and the United Nations. If you look to some of the Sustainable Development Goals, a few of the indicators that are in there, she with her bare hands helped build. But today she's here to talk about a study that we did on this growing crisis on opioids. Please welcome my colleague, Cynthia English.
Good morning, everyone. Thank you for joining us. We're very excited to be able to help inform the national conversation about the opioid epidemic by bringing in, as John mentioned, the voice of the American people. About 5 minutes ago now, we released a special research brief about the opioid epidemic, about the Americans' views of this crisis, and also about their views of some of the alternative ways in which they might treat pain. You all have also received a copy of that in your folders, but this is available online now. I just want to cover a few brief highlights from this study. So every year, the Gallup organization does a study of over 5,000 Americans, nationally representative, as part of the Gallup Palmer College of Chiropractic annual study of Americans. And we ask them about a lot of different topics. We ask them about their pain. We ask them about how they treat their pain. And while all of us in here are aware of the opioid epidemic, we probably all have very different opinions about the root causes of it, who's to blame, and what the solutions are. So this morning, we're going to share a little bit about how the American public feels. And really, these are the patients of the healthcare profession. So first of all, we just wanted to give some baseline statistics. There's other data out there like this, but I think that what is really telling about this information is how many Americans right now are dealing with significant neck or back pain. And it's 1 in 4, just over 1 in 4 adults, just in the last 12 months say, I've had back and neck pain significant enough that I saw a healthcare provider about it. And if you look at the bottom row there, only 1/3 of Americans say that's never happened. And as they age, many of them will come to experience significant neck or back pain. So while there are many different types of pain that people struggle with, this is one of the top reported pains that people are having in the US is back and neck pain. And for many people, it's an ongoing chronic problem. Of those adults that had significant neck or back pain in the last year, 2/3 of them have been dealing with this for more than 3 years. So I think patients are out there looking for different ways in which to treat their pain. They're trying different alternatives. And for many of them, they're not working because they've been dealing with this chronic pain for years. So one of the things we wanted to ask our newest sufferers of back and neck pain is, how are they treating that pain? And one of the ways they do that is with pain medication, over-the-counter and prescription. So if you just talk to the folks that say, I had that significant back pain in the last year, we find that 70% of them at the top are taking some type of non-steroidal anti-inflammatory drug to treat their pain, and about half are taking acetaminophen. These are over-the-counter options for them. If you look at the very bottom, we find that 1 in 4 new back and neck pain sufferers are taking an opioid just in the last 12 months. And of course, there are millions of other Americans who have been taking opiates for years. So as we dug deeper into this topic over the last couple of years, we wanted to go to the American people and find out broadly, how are they feeling about this opioid epidemic? And what we found is that when we asked people, what's the biggest drug problem in your area, local drug problem, what we find is that many people in the US are identifying opiates as a major drug problem where they live. So they were able to select from 6 or 7 different drug types that I'll put up on the screen, and told us whether each of these things is a crisis, a serious problem, somewhat serious problem, or not much of a problem at all. And these were the different drugs that we asked about: heroin, cigarettes, cocaine, alcohol, marijuana, and prescription painkillers. What we found is in the US, opiates are viewed as the most serious local drug problem. 44% of adults in the US are telling us that it is a crisis or a very serious problem in the local community where they lived. Next on the list was heroin at 42%. So the American public is very aware that opioid epidemic is happening, and it's a problem right where they live. It's not something they view as an abstract, yeah, that happens, but not where I live. Many Americans know that in their local neighborhoods, this is a serious issue. So we asked them, whose fault is it? Who do you place a lot of blame on for this opioid crisis? And among the Americans that are aware of the crisis, which many are, you find that just over half of them say, well, I think the pharmaceutical is a lot of blame here, pharmaceutical industry encouraging doctors to use opiates. But nearly just as many say, no, it's the doctors overprescribing painkillers to their patients. So more than half of Americans are saying they place a lot of blame here, but they're not done placing blame yet. Just about half say, well, it's a lack of public knowledge about the dangers of opiates that I place a lot of blame on. And lastly, and relatedly, no, it's the patients. The patients are demanding that they be given a prescription to ease their pain. So as we can see from this data, there's a lot of blame to go around in the views of the American public. And so within the profession, while there might be some finger pointing or saying this group is responsible, the American public doesn't see it that way. And this data comes from a June and July 2016 Gallup poll. So this year, we really wanted to find out more about the preferences of the American people. What do they want? When they're in pain, what is their preferred way of treating it? Do they want to get a prescription pain medication immediately from the doctor? Or do they want to try another way of addressing that pain first? What we found overwhelmingly is that a large majority of Americans, 78%, say, I'd prefer to try something other than a prescription pain medication first to try to treat my pain. It's not that prescription pain medication can't be part of their treatment plan or solution, but there's an overwhelming demand here for something more than just a prescription. And as we dug deeper into some of the alternatives that people might use to treat pain, we really wanted to understand what their perceptions were of the safety of the different treatment options. So we gave them some options and ways in which people might treat neck and back pain specifically. And what we found is that Americans are much more likely to describe physical therapy and chiropractic care as being very safe, which are non-drug treatment alternatives, than to say that about over-the-counter prescription pain medications or prescription pain medications. So only 12% of adults in the US would describe prescription pain medications as very safe. And then this next color here shows somewhat safe. So you can see a majority of Americans, a large majority of them, are saying that physical therapy is either safe, very safe or somewhat safe. 3/4 of Americans describe chiropractic care as very safe or somewhat safe. And as you start to look at the prescription pain medication, you'll see that it is over half of Americans that are saying it's somewhat safe. So there may be some reservations there. It may be that different attitudes are being formed by the way in which people use these pain medications. And then these darker gray boxes are representing the number of people that say these Different options are not very safe or not safe at all. And if you look at the prescription pain medication row, which is down the second one from the bottom, you see that 1/3 of Americans describe prescription pain medication as either not very safe or not safe at all. So Americans are aware that there's a risk here. They're noticing the problem in their own local neighborhoods. Then we wanted to ask about effectiveness. What do you view as being effective for treating significant neck or back pain? And what we found is, again, non-drug treatments are more likely to be perceived as a very effective way of treating significant neck or back pain. And for many folks, this may not even be the methods that they personally have tried for themselves or have tried yet, but their perception is that some of these non-drug alternatives are more likely to be described as very effective. And you can see pain medication there in the middle. About 1 in 5 adults in the US would describe pain medication as very effective. And then these are the numbers on somewhat effective. And again, if you look at that middle line, you see that about 3/4 of Americans, or about half of Americans, would say that prescription pain medication is somewhat effective. But the question we need to ask ourselves in the health policy community is, what does it mean to be effective? Is it 1 minute I'm in pain and a few minutes later I'm not? Is that effectiveness? Or is it a long-term effectiveness to help deal and heal my condition, which some of these non-drug treatment alternatives are offering? And then these are some of the remaining data on people describing them as not very effective. And lastly, and before I hand it over to our keynote speaker, we are really interested in digging into the preferences that people have. What do they want? And so one of the questions we asked of all of our respondents, over 7,500 Americans, was, suppose you did have significant neck or back pain. Some of them do, some of them don't. But if you did, and you had the opportunity to choose among different treatment alternatives, and you knew the cost would be the same to you, because we know that cost can be a barrier for some, who would you most like to see about that back and neck pain? And what we found is that just over half Americans say, well, I want to see my medical doctor. That's my first stop, the person I'd most like to see. 28% of Americans would like to see the chiropractor first for treating their significant back or neck pain. And you can see the statistics in some of the other treatment methods. But I think what all this data really brings to light is that Americans have preferences and ways in which they want to treat their pain that are different than the prescription pain medication, which can be part of their pain management. But complementary approaches, like some of the ones we measured, are also ways in which people can address their pain. And our panelists and our keynote speaker will be speaking more about some of those complementary approaches today. So now I would like to introduce Dr. Aaron Carroll, our keynote speaker today. And he's going to dive even deeper into this with some of the research that he's found and done on the opioid epidemic and also some of the possible solutions for addressing it in this country. Dr. Carroll is a professor of pediatrics and associate dean for research mentoring at Indiana University's School of Medicine. He's also the director of the Center for Health Policy and Professionalism Research. Dr. Carroll's research focuses on the study of information technology to improve pediatric care in areas of health policy, including physician malpractice, the pharmaceutical industry, physician relationship, and healthcare financing reform. He's a regular contributor to The Upshot at New York Times and has written for many other press media publications. Please welcome Dr. Carroll.
Thank you so much, and thank you for everyone for being here. This topic is just everywhere these days, and so it's great to get to talk about it, and it's great that it's finally getting the attention that it deserves. But it is hard to overestimate how big the problem is, and we're trying to deal with it. Although it's fascinating to see information that's going to even update some of the slides that I might show you. It is difficult to get a handle, as I said, on the number of people who are dying in the United States due to drugs and drug overdoses. All the other lines, you can see most of the other developed nations are sort of moving in the middle. They're around 1%. The United States, as that red line, is on a track all by itself. Most countries are far below it. Significant numbers of people are dying in the United States due to drugs, and the real problem with that these days is opioids. And it is really an American problem. When we talk about opioid, and by the way, the first 3 slides that I'm showing you here, I've cribbed from many of my colleagues at the New York Times who've done a great job in covering some of this. But when we look at what are the drugs that are causing deaths in the opioid epidemic, it's important to recognize what has changed in the last decade or so. Prescription opioids were a real problem and the problem in the beginning of the decade. But as we got to about 2010, not minimizing it at all, that became flat. The problem is that everybody started to transition to heroin, and in the last few years, the real problem has been fentanyl. with people actually transitioning to other opioid medications, even the non-legal ones, causing significant amount of death in the country. It is interesting to look at where these deaths are because they overlap with so many other problems in the United States. The darker shading is more deaths. You can see that the real problems lie sort of in Appalachia, heading into the south perhaps, and the southwest. And this is where significant numbers of people are dying. It also happens to be where significant numbers of people are poor. It also happens to be where we talk about health disparities and the fact that people lack access to insurance. But there is a significant concentration of these deaths. We can target them and sort of know where they're happening. The effects of this are unbelievably pervasive. So just last week, Brookings Institute updated a study that they'd done a year ago. And in 2016, they showed that nearly half of men aged 25 to 54 who were unemployed took pain meds on a daily basis. And so people began to question whether the difficulty we've seen with working age men not entering the labor force was perhaps even more associated with the opioid epidemic. 2/3 of those people took a prescription pain med on a daily basis. So 2/3 of the men aged 25 to 54 who were not in the labor force were on a prescription pain med. I mean, of those who took an opioid were on a prescription pain med. And last week, that same economist updated it and showed that the increase in opioid prescriptions from 1999 to 2015 accounts for 20% of the decline of men and 25% of the decline of women in the labor force. So significant numbers of people who are not working, who we believe should, can actually be attributed to the increase in opioid use in the United States. This is a health problem, this is an economic problem, it's affecting every facet of our lives. And if you look more clearly, again, where are these people not entering the labor force because of opioids? Again, it's Appalachia, it's heading into the south, it's the southwest. Now granted, there are some other patches of the country as well, but again, it's a pretty focused area where people are not working, and it's perhaps because of pain meds. People are dying, and it's because of pain meds. Pain meds are a real problem. It's also where the prescriptions are. These are the prescriptions per million people. And as you can see, again, Appalachia has a significant concentration of pain medication prescriptions, some in the southwest as well. Northern Michigan is another hotspot and they're there. But again and again and again, we're seeing that opioids are a problem, prescription opioids are a problem. It's a problem in all these areas. It's also an American problem. Although we account for about 4% of the world's population, the United States accounts for more than 1/4 of the world's drug overdose deaths. We have a very concentrated amount of health problems because of this. About 8.5 million Americans misused opioid painkillers in 2015. About 2.5 million were addicted to either painkillers or heroin. That's a significant number of people in the United States. Compare that to Europe, where they have more people, but only about 1.3 million people have issues. They have about 20% of the deaths due to opioids that we do here, even with a significantly greater population. We're treating with prescription opioids today about 50,000 doses per million people every day in the United States. That's an enormous amount of drugs. That's twice the amount of prescriptions or doses per population than any other country in the world. It's significantly more than many other countries. And although we consume about 4%, again, of the world's population, we're consuming about 30% of the world's opioids. So again, even with prescriptions, we're taking an enormous amount of these drugs. We're the only users of some opioids. In fact, 99% of the world's hydrocodone supply is taken by Americans. This is a drug that doesn't even exist mostly in the rest of the world. It's something that we just use here. We could spend the whole day talking about how we got here, and we could argue about it. But speaking as a physician, I'm a pediatrician, as well as a researcher, it's very hard to overemphasize how much the changing culture and focus on pain in the 1990s and on changed this. So in the 1980s, to start this off, there were a couple very influential journal articles that downplayed the risks and the dangers of opioids. They were not well-designed randomized controlled trials. They were not cohort studies. They were not even case control studies. In the sense, they were reports following patients who were on opioids and then claiming, look, in my experience, no one's really ever gotten addicted to these things or no one's really had a problem with them. Therefore, we should start to feel more comfortable about them. There have been many articles published on potential conflicts of interest that existed that were not declared with some of these articles, but it is almost irrelevant at this point. The issue is that we became much more comfortable as physicians and then as patients and as the entire healthcare industry with the idea that opioids were a lot safer than we had feared before. Then in the mid-1990s, the pharmaceutical industry began to get in on the game and to aggressively market, shall we say, a number of different types of prescription opioid drugs, which again, we could spend all day talking about this. People have done exposés talking about whether or not there were misleading claims about the dosing that was offered, whether it was truly safe, how much of the information was made publicly available. It was a perfect storm. It was a perfect storm of, one, a need, focusing on patient satisfaction and pain. We became much more concerned, and we have continued to be in the last few years, about patient-centered outcomes, about worrying and fixing things that are not necessarily important to doctors, but important to patients. And pain was one of them. And because of this, coupled with overly aggressive marketing and coupled with a fixation on pain, we began to use these drugs more and more commonly. This, of course, led to things like pill mills and many institutions putting out far more opioids than they should, which, of course, led to the heroin market expanding because as people became addicted to these drugs and could not get them anymore, there needed to be a black market way or an off-label way, if you will, of trying to get these same drugs. And then the real problem in real mortality in the last few years has been fentanyl. Fentanyl, of course, is not anything that anybody would prescribe. It should not be legally obtained by anyone on an outpatient basis. It is incredibly dangerous. It is incredibly dangerous even for the people who are trying to control the problem, and that has led to a significant bump in the increase of deaths in the last few years. But again, it is hard to overestimate. When I trained in the late 90s and in 2000s, and focusing on pain was the single biggest thing that the clinics were always concerned about. I've done a lot of work at electronic medical records and clinical decision support, and I cannot again overestimate how concerned the clinics were with making sure that we checked the pain on a 0 to 10 scale of every child who came into clinic every single time, no matter what they were there for. Pain became almost the focus. People have referred to it as the fourth vital sign. And because of that, it began a slow tumble towards wanting to treat that pain, treat it easily with opioids, and that led to many other difficulties. But the bottom line is that we treat pain dangerously. We use dangerous medications to treat pain. Sometimes we even use procedures which are dangerous as well. But these are not benign therapies, and they lead to problems, and there's got to be a better way. It's important to recognize that pain cannot be viewed in isolation, nor can opioid use. In fact, other drugs are often involved when people become addicted and abuse opioids or abuse other medications. About half of heroin-related deaths in the United States also involve alcohol, which absolutely should be thought of as a drug in the same way that people use it to treat pain and other symptoms. About a third of prescription painkiller-linked overdose deaths are also linked to benzodiazepines. And I thought it was interesting. A few minutes ago, we saw a slide on how many people are treating pain with benzodiazepines. As we mix that with addiction to opioids, it becomes incredibly dangerous. And too many deaths are due to this. But it's also important to recognize more holistically that most people with opioid addictions have a pre-existing mental illness or psychosocial disorder, and that gets coupled in that as well. These include, of course, depression, post-traumatic stress disorder, attention deficit hyperactivity disorder, anxiety disorders, bipolar disorder, personality disorders. More than 90% of those who are addicted to heroin will have one of these issues. About 2/3 have experienced significant childhood trauma, meaning that there is something else in their medical history or psychosocial history which perhaps made them more predisposed to have pain and also therefore to get opioids and have problems. And among women, the rates of sexual abuse can be even higher in the past. So there's a huge milieu, a huge issue about what is going on with patients, and we're just treating pain. And we often use, again, the most complicated and the most dangerous therapy around. But we should not ignore the fact that people are in pain. And we just heard some data on this. My data often come from more peer-reviewed literature, but the Gallup data are frightening in and of itself. A 2011 report from the Institute of Medicine argued that about 100 million people in the United States suffer from chronic pain. It would seem that, given the data we've seen today, that it's at least that bad, if not worse. That was, back in 2011, about a third of all Americans. That seems still on par with how many people are reporting pain currently today. The national economic cost of chronic pain is about $600 billion with a B dollars a year. About half of that is in actual treatment of the pain, and about half of that is in lost economic output or lost productivity due to people having pain and not being able to work. It's also what we see when I showed you earlier slides with the decreased people in the labor force. And so we're seeing a significant cost because of the pain. But pain is also a very still unique and subjective experience. And so it is difficult to get a handle on any person's pain without understanding everything else that's going on. And again, trying to treat it with a one-size-fits-all opioid treatment does not work. We often underdiagnose and undertreat pain. This is the other side of the coin that we ignore too often, is that we talk about overuse of opioids and we talk about focusing too much on pain, but you have to also acknowledge that there are a lot of people in the United States who still have pain that aren't treated well, and that we don't acknowledge the pain can also be linked to other issues that need treatment, and that winds up in a spiral that makes everything worse. We also treat very liberally when we do find pain. There are reports in pain management settings, and I'm citing here a review article from Pain Physician in 2012, that said in pain management settings, more than 90% of the patients seen there can be given opioids. So people who make it on referral to a pain specialist will often be given an opioid. But pain management clinics, although that's a problem, actually account for a small percentage of the overall treatment of pain in the United States. The vast majority, of course, are seen in primary care settings. About 20% of patients in primary care settings are still long-time users of opioids. And more than 60% of them have received opioids from their primary care provider. So although we can focus on the pain settings and we can worry about the pill mills, it's in the everyday primary care settings that most of these drugs are being given out. Many chronic users have been prescribed at least 2 different opioids from at least 3 different providers, meaning that we're not coordinating our care very efficiently, and we're winding up giving multiple drugs and multiple prescriptions to patients. And it's also interesting to note that about 80% of prescribed low doses of opioids from a single provider, in other words, providers will say this is a low dose, 80% of them still account for 20% of overdoses in the United States. So even when providers think that they are on the safe side and giving people just a touch of opioids, that still accounts for a significant number of deaths in the United States. And the typical drug-seeking patient, which is of course what for years physicians in the system were concerned about, it's the patient who's trying to deceive us and go to multiple different providers in order to get the maximum amount of drugs, they account for less than half of the overdoses in the United States. Most of the overdoses are what we would consider to be patients who are not actively seeking drugs. There are alternatives, and some of them were mentioned already, and more patients have been looking for them on their own. So this is a survey that was done in 2012 that had talked to 12,000 people who had back pain, spine problems, and found that more than 40% of them were users of complementary or alternative medicine. And there are many different ways to describe this medicine, Eastern, complementary, alternative, it doesn't matter, but it is things other than what we would consider normal traditional medicine. Users of CAM, interestingly enough, had significantly better self-reported health, education, comorbidities, meaning that they didn't have as many side effects. So in general, the patients who were using CAM, who were not using traditional medicine to treat their back pain, were reporting better results. Now, of course, those could be biased because patients will sometimes do this. But it's interesting to note they also cost less. The adjusted annual medical costs among CAM users for back pain was $424 lower on average for back pain-related costs over a year. For overall healthcare costs, they spent about $800 less. So the users of complementary alternative medicine, besides reporting better overall outcomes, also seem to be spending less money. Now, again, that could be biased. They could be just less, more thrifty in general. So the researchers used propensity scores and some other sophisticated techniques to try to adjust for that, and found that even after adjusting, CAM users used about $500 lower for back pain costs and about $300 less every year for overall healthcare-related costs. So they absolutely were spending this, and mostly it was due to lower inpatient expenditures. They did not get to the inpatient setting as often, which lowered their overall costs. Back pain is the easiest example to talk about. because it's the most widely studied cause of pain that exists, and there have been many, many studies on it. About 2 out of every 3 people, and this study's from years ago and we just updated, are going to have significant lower back pain over the course of their life. The vast majority of people will. Most back pain, however, resolves, and so doing as little as possible is often a good idea, because the vast majority of it will get better over time. But that is not what we do. We will often try surgery, we will try injections, and very, very often we will try to treat this with pain meds. Recently, and this I think it was just a couple years ago, researchers looked, actually this might have been even earlier this year, researchers did a big systematic review in our meta-analysis, meaning they did a study of studies to look at all of the new studies that have been performed since 2011, when a lot of new randomized controlled trials have been performed, as well as everything that had existed before. And they found that the evidence from 15 randomized controlled trials, which included a lot of patients, showed that spinal manipulation, what we normally think of chiropractors doing, but many osteopathic doctors can, and many other practitioners in the medical field as well can do, spinal manipulation significantly improved pain scores, meaning that it worked in reducing pain. And the evidence from 12 randomized controlled trials from about as many patients showed that it also resulted in improvements in function. And so again, the growing evidence showed that something that perhaps we had not paid enough attention to worked better than we thought. And then in February, there was another systematic review that looked specifically at non-pharmacologic therapies, and it generally agreed with all the other research trials. And it said again that all of these other therapies that you might try for back pain work and don't carry with them the significant side effects that opioids do. And based upon that review and other evidence, the American College of Physicians released new clinical practice guidelines for treating what we call subacute back pain that said, look, if you have pain, try heat, try massage, try acupuncture, try spinal manipulation. These are the things that we should be trying as first-line therapies, not drugs. Why? Because again, the vast majority of back pain will get better on its own. We should be looking for things that don't have a lot of side effects or a lot of danger. These things don't. Some of them have been proven to work, even in randomized controlled trials. But it's also important to remember that for management of long-term chronic pain, the evidence on opioids is not always as strong as we think it is. And so a lot of the therapies that we do use that are very dangerous are not nearly as proven as we believe that they are. One of the big issues is that our healthcare system does not make this easy. The options that I just mentioned are often out of reach for many patients. They cannot afford to go to a chiropractor. They cannot afford to go to a doctor. They don't have insurance. In fact, that is still a big problem in the United States, is that many patients still lack insurance, which means they can't afford it. Even if they do, insurance often does not necessarily cover comprehensive pain care in the ways that we would like it to. And even if it does, there may not be a nearby pain clinic or a doctor who can handle this, or someone else. And they may not find physicians who are open to the idea of using these different ideas or these different treatments or push them in that direction. And because of that, we default again to what we know, which is often opioids. And so the system is still to some extent built to drive people to traditional therapies, which often wind up being very dangerous. Now, we've been trying to fix this. There have been some initiatives at the federal level, at various state levels. We have, as I showed you even on a slide, been pulling back on the prescriptions of opioid drugs. There's definitely increased awareness. Physicians are definitely thinking twice about it. And the public in general, I think, knows about the dangers more than they used to. And prescriptions have been falling since 2010. So we have made some progress there. Some states have also limited doctors' ability to prescribe them, putting limits on it through regulation or requiring pre-approval before they do prescriptions. The federal policy has also tightened some of the regulatory schedules and made it more difficult. The CDC has guidelines that also ask doctors to avoid prescribing for chronic pain opioids, except in some circumstances. And so there has been sort of the all-hands-on-deck approach to try to slow what we have been doing with respect to opioids. The problem is that, of course, cutting back on opioids is incredibly hard, not just for policy, but also for patients. Abruptly cutting off a patient's supply of opioids can be very dangerous. People do die of withdrawal symptoms, and unless they are properly managed, then they could be at significant risk. So this is not an idea where we can just say no, we can just turn off the spigot and just demand that nobody use opioids in the future. As I just said, withdrawal can be incredibly painful and dangerous. Even more so if we just cut it off, what happens is that many of the patients who lose access decide to switch to the illegal forms of these drugs, which are heroin and now fentanyl, which are very dangerous. And so part of the increase, of course, in the use of heroin and now fentanyl is because people got hooked on opioids, and then when they could no longer get what they needed or their problems increased, they moved to illegal forms of the drugs. And so we have to acknowledge that just going cold turkey will lead people potentially to far more dangerous circumstances. The symptoms of withdrawal are so bad that most of the success that we've seen with respect to treating opioid addiction is still Medicaid-assisted treatment. So this is using methadone, buprenorphine, naltrexone to combat the opioid cravings, to manage people as they withdraw, and to do that. We have problems with this, of course. Well, first of all, the good news is that medication-assisted therapy can cut mortality among opioid addiction patients by half or more. And there have been good studies that show that medicated-assisted treatment is really what we should be doing. It is the gold standard for opioid addiction and treatment. It is unfortunately still very, very hard to do in the United States, both, again, for policy reasons and often for money. It often remains inaccessible, and a lot of that is often due to policy. The federal government caps how many patients doctors can prescribe buprenorphine. To become allowed to do it, it requires a reasonable amount of training. And then there's a waiting period, I think, of which you can actually prescribe 30 patients a year, and then over time, after that trial period, you can get to a maximum of 100 patients per year. Doctors don't often want to do this. We don't incentivize them to do it. One, it can lead to patients going to their clinics that they might otherwise, not see or want in their treatment, and want in their clinics, which we have to be very honest about. It's also increases the risk. Doctors feel that there's a stigma carried along with it, and there was a 2012 analysis that found that if every doctor who's allowed to prescribe buprenorphine did so at the maximum rate in 2012, we could still only treat half the people in the United States for opioid misuse or abuse. And so even if we maximized capacity, we still could not possibly use the treatment on everybody who has an opioid problem in the United States, and we're nowhere near maximizing what we could do. And so we still, even because of policy, are unable to get a handle on this. There are also various state policies that don't believe in either methadone or the use of naltrexone or naloxone. And so getting everyone on the same page as to how to get a handle on this and how to move forward is very difficult. So what do? Well, the best thing is with almost any medical problem would be prevention. Not getting people hooked on opioids in the first place is probably the best thing that we can do. And that's, I think, what we're going to talk about also here today. What are the other things that we could do that will help people treat pain that will not get it? For those, of course, who are already on or addicted or misusing opioids, we have to make it easier for them to get treated. It's too difficult in the United States. The financial barriers are too high. The policy barriers are too high. And we're not coordinating everything optimally to try to get there. We also have to address the problems that lead to addiction. It's important, again, to note that pain is not in isolation, that addiction is not in isolation, that these things are often coupled with and intertwined with mental health issues, personality disorders, and we say it over and over again without ever fully committing to it, but we have to get as good at preventing and treating mental health issues as we do physical health issues, because that is part of this problem as well. And as long as we continue to try to treat this as a drug problem in isolation, it'll be very difficult to get a handle on it as well. And we have to find ways to treat pain better and more effectively. We have to be open to the idea that some of the stuff that we would not traditionally use, that would not be traditional medicine, we should be rigorous in studying and make sure that these things work. But our goal is always to weigh the benefits of what we're doing against the harms of what we're doing. And when there are few harms, it's okay to go with things that have questionable benefit. The problem is that opioids have a significant amount of harm attached to them. It is well documented and well known, and to continue to try to use them for questionable benefit when there is significant harm doesn't make a lot of sense. And at that point, we have to broaden the game and think about other alternatives and things that we can do to treat the very real problem of pain and everything that goes with it without also putting patients and the public in danger. And at that point, I'm going to say thank you, and we're going to set up the panel here very quickly and start talking to some other experts about what they think the future things we can do for opioids are. But again, thank you very much.
I'm going to introduce our panelists as they make their way to the stage. We are just honored this morning to have such a great group of health policy professionals join us today to help us think through what we've heard in the research and ways in which this might be applied in our country. So I will first introduce, in the order, this direction, Dr. Joe Selby. He's the Executive Director of the Patient-Centered Outcomes Research Institute. He has a medical degree from Northwestern University, and he will be speaking, I think, in a very interesting way in which thinking about our patients first and patient-centered outcomes can be helpful in thinking about this topic. Then we have Dr. David Shurtleff. Pardon me. He is the Deputy Director of the National Center for Complementary and Integrative Health, a component of the National Institutes of Health. And then we have Dr. Caroline Clancy, the Deputy Undersecretary for Health for Organizational Excellence at the Department of Veterans Affairs. And last but not least, Dr. Christine Gertz, the Vice Chancellor for Research and Health Policy at Palmer College of Chiropractic, and the CEO of the Spine Institute for Quality, Spine IQ. Thank you.
So I think we're going to start with just some prepared remarks from each of the panelists, then we will transition into some questions, and I'd like very quickly to get to audience questions. So while I get things going, at that point, please raise your hand. There will be people with microphones who will come around to get your questions, but we will start with Dr. Selby.
Okay. Thanks, Aaron. Hello, everybody. Thanks for being here. I want to also thank Gallup and Palmer College for really a very useful additional study. As Aaron said, it's coming at us from all sides, but I think it's going to take that much. Your remarks were fantastic, Aaron, and really set the stage nicely. I got to say that the one statistic that jumped out at me maybe the most from the survey was that in the past 12 months, 25% of people reported having been prescribed an opioid. That shows you that we have a background level of activity that is overwhelming. So I'm going to try to give you a perspective from the Patient-Centered Outcomes Research Institute, PCORI. We were set up as part of the Affordable Care Act, and our sole mission is to conduct comparative research at the request, at the instruction of our stakeholders, and those are first and foremost patients, but also caregivers, clinicians, insurers, policymakers. We take questions in and work with the range of stakeholders to try to come up with the right research question. And I'm here to tell you that although back pain and chronic pain have been studied immensely, that is still the area where stakeholders, and I'm talking about patients, payers, clinicians, have come to us. In fact, when we came into existence, there was already pressure to begin studying both back pain and chronic pain. A few years later, the pressure increased, so about 2.5 years ago, the pressure increased on studying opioids specifically. So we now have large portfolios in each of these. The way we work is we bring these people together, and I have to say that pain is one of the more complex conditions. You have multiple, even in back pain, you have multiple mechanisms from muscular to neurologic to arthritis. You have multiple specialties involved, and they all see pain somewhat differently. You have patients who have very different social and economic circumstances, and that leads to them having very different preferences for what they want. So it's hard to get to what is the exact right question. But I will tell you that we have about $60 million dedicated to back pain at this point, and more coming. So we have an announcement with a couple studies in how you prevent the progression from acute back pain to chronic back pain. Again, I think it's driven by patients' fear and clinician concerns about two things. Number one, opioid use chronically, chronic pain and opioid use, and number two, back surgery. As you saw from the survey, back surgery is something that's no one looks forward to. So we have one announcement in preventing the progression of back pain. We have one announcement that has not been funded yet, soon to be funded, on comparing back surgery, fusion, spinal fusion, with non-surgical alternatives. And the third, and this probably may be the most relevant, how you combine and sequence therapy. So what should you start with? And I will tell you that I don't think that any one of these treatments is going to come out to be the end-all and be-all. I think we would have recognized if it were true. The same thing in opioids. We have a large announcement, and we funded about 6 projects on preventing the initiation of opioid therapy. So this is where we get studies of spinal manipulation, chiropractic, physical therapy, massage, and a second one on treating patients who are on relatively high doses of opioids chronically with the goal of reducing or getting off the opioids. And that's particularly where we see things like cognitive behavioral therapy and mindfulness meditation in there, along with massage and spinal manipulation and other treatments. And the third one in opioids is, as Aaron mentioned, medication-assisted treatment. And we still do have a vast shortage of physicians willing to take on medication-assisted treatment. I think really we have a national cohort of physicians who are not well trained in addiction medicine, to say the least. They're not really well trained in the interaction of psychological and physical factors. We are a pretty simplistic bunch who think we've got an answer for everything, and that doesn't work out so well in this. But I will just say in closing that I think the research that will serve us will have to ask very specific questions. If we know the answer to this question, it will really change our practice. It'll have to focus on multiple outcomes. And I think this is where we'll get some insight when we look not only at pain, but when we look at ability to function and quality of life. I think some of these treatments may break out as being preferentially beneficial for being able to get back to work or being able to report that your quality of life is better. I think that there's going to have to be multiple studies of multiple comparisons for the complexity reasons. And I also think, and this is something that Pecori puts a lot of weight on, is the notion of what works for whom. It's, I think, pretty clear that there is not a standard pain or back pain patient, that they come in a very, very wide variety of presentations, and predictably different treatments are going to work better. So we really push our data and our researchers to help us understand what works better for whom, because that's the kind of information that patients and clinicians can really sink their teeth into and say, tell me what your situation is, and then you look at the evidence for what works better for people like that. So I'll close and just say that outstanding day so far, crucial question, nothing more patient-centered, nothing that, I think the bottom line message that patients get this is crystal clear.
Well, I want to thank Gallup for inviting me, and Dr. Carroll, I really appreciate your comments. I think they really capture where we are in this issue of pain and opioid crisis. Just as Cynthia pointed out, I am the Deputy Director of the National Center for Complementary and Integrative Health, and we are part of the NIH. So our mission is really research-focused and research-based, and our mission is really to define through rigorous scientific research both the safety and the usefulness of complementary and integrative health approaches and their roles in improving health and health care. And really, our research needs to be useful and used. It's really designed to inform the patient, clinicians, and policymakers in decisions using evidence to drive those decisions regarding integrative health, the use of integrative health approaches and complementary health approaches. So our research focuses, a lot of our research, about 40% actually of our research, focuses on pain research. And it's really divided into 2 areas. One is our intramural program, which is on the NIH campus, looking at brain mechanisms associated with pain, the basic understanding of the experience of pain, both using preclinical models and human neuroimaging to understand how the brain changes in a pain condition. Our extramural program, which funds medical schools and colleges and universities throughout the country, is a much broader program focusing on both the basic science, translational research, up to large-scale clinical trials and effectiveness research, which is really where the rubber meets the road in terms of understanding how to best treat patients. And there certainly is, as we've been hearing, there's a need for pharmacological approaches for the treatment of pain. And I'm heartened to see a sea change really over the last couple of years and how both professional organizations such as the American Medical Association and the popular press is starting to understand how and the importance of at least exploring the use of non-pharmacological approaches for the treatment of pain. And just to give you a couple examples, in December of 2016, the Journal of the American Medical Association in their Medical News and Perspectives actually highlighted NCCIH research on complementary and integrative health approaches and really talked about the need to do more research in this area to help patients who may be mistreated or undertreated for their chronic pain. So here we have a major medical journal speaking about complementary and integrative health approaches. And just more recently, in June of this year, the Scientific American published an article on rethinking relief. And in that article, they really pointed to the opioid crisis driving the public and clinicians thinking and rethinking about the use of complementary and integrative health approaches for the treatment of pain. So here I see a change in how the public and the medical profession is perceiving treatment of pain. And related to the data we've already seen, we supported in 2012 the National Health Interview Survey in part with the CDC. And that report showed that about 25 million adults experience chronic pain, which is not too dissimilar from what we've been hearing today. But importantly from that study, it also showed that many Americans seek complementary and integrative health approaches for the treatment of pain, something Dr. Carroll mentioned as well. And this involves spinal manipulation, it involves meditation, it involves acupuncture and other approaches to treat their pain. And it's not just the civilian population that's experiencing pain. In fact, veterans are about 40% more likely to experience severe pain than non-veterans. So this has led to a variety of clinical guidelines. Dr. Carroll mentioned the American College of Physicians. The Mayo Proceedings put out a review in 2016 reviewing about 105 randomized controlled trials looking at non-pharmacological approaches for treatment of pain, and came up with some very interesting recommendations about what complementary approaches work and, frankly, what complementary approaches may not work for specific types of pain. What this leads us to say is that, yes, the research is informing practice, but there's still a lot of gaps in the research and what we know and what we don't know in terms of informing the public, the patients, and the clinical healthcare providers. And just finally, I'll end on something that we're really pushing and we'll be announcing in more detail next week, is we've formed a partnership with the Department of Defense, Department of Veterans Affairs, to launch a $70 million project over now the next 6 years that will really take these approaches into the clinic, into the real world, what we call pragmatic or effectiveness research, to determine what works and how it works with veterans suffering from chronic pain, service members suffering from chronic pain, and really beginning to understand how we can implement and integrate these complementary approaches in these healthcare systems that we hope will then generalize not only to the military and the veterans population widely, but also to the general public. So we're very excited about that initiative, and you'll be hearing more about that in the coming weeks. So thank you again for your attention, and thank you again for inviting me.
Great. Good morning. Carolyn Clancy from the Department of Veterans Affairs. First, I'm very excited about the report, and Dr. Carroll, you did a terrific job putting this all in context. The report echoes findings that we're increasingly hearing from veterans as well. As my colleague just pointed out, if 1 in 3 Americans suffers from some kind of chronic pain, the rate is much higher among veterans, often due to service-related injuries. Some of those service-related injuries are, of course, when they're very severe, are treated acutely with opioids. And then when those individuals transition into our health system, they come to us on those medications and so forth. So not initiating the trail is not something that we always have as an option. And secondly, it also means to us that we have to work in close partnership with our colleagues from the Department of Defense, and that has been really terrific. Now, what we've seen in the past few years is a very strong focus on making the use of opioids visible to all of our prescribers and to veterans. And we've seen pretty important and dramatic reductions in the number of veterans on chronic opioids, the doses that they're on, and very importantly, the number of veterans who are on an opioid and another drug, because many of our service members, former service members from recent conflicts have come home with important mental health disorders as a result of their service, whether that's post-traumatic stress disorder, sometimes complicated by traumatic brain injury, or other types of diagnoses, all of which makes treating pain effectively more challenging. But I think Cynthia English put it very, very well in her opening remarks when she said, we really need to be focused on how do you manage this over the long haul? And that's really the big gap in our research evidence base to date. Isn't what works or not over a short period of time. I mean, in the research world, following people for a year is kind of a big deal. And it's a great thing when we do it. But frankly, most of our veterans want to know, how do I live with this and manage it and actually get back to what I want to do and get to my highest level of function? So to that end, we actually set up a National Center for Complementary and Integrative Health just about a year ago. Very, very excited about that. And on October 1st, we will be launching what we're calling a whole health focus in 18 of our facilities. These are our flagship sites, one in each of our regional networks, that will be focusing on a whole health approach. The most important group that will be a priority for this initiative are veterans suffering from chronic pain who are also using chronic opioids to manage that pain. And the issue, again, and I think Dr. Carroll said this very well, is not to just say no. That doesn't work that well. So it's not just that we've overlooked the simple, obvious solution here. The issue is, how does a clinician and a veteran work together to get to a better place? Not surprisingly, and I don't have good numbers to back this up, but my impression is that just as the American public in general has been more enthusiastic about complementary and integrative health interventions for quite a few years, I believe that we see quite a bit of that among the veteran population as well. So we are working to expand that capability. We have taught many of our frontline clinicians a technique called battlefield or auricular acupuncture, which has helped many of our veterans. And Dr. Carroll made the point that these treatments are not always easily available. And 1/3 of the veterans we serve actually live in rural areas. So there may not be an acupuncturist on every other corner. There may not actually be a hub of activity on every other corner. But we have also learning and funding some very important research about how much we can do remotely through telehealth, whether that's mindfulness coaching, cognitive behavioral therapy, or other kinds of modalities. So we're very, very optimistic about the future. The last point I would make is, there's a very important and highly regarded opinion leader in our system who's a primary care physician who also has effectively become a specialist in addiction medicine and pain management. And I was asking her how she came to the VA. And she told me she couldn't make it in the private sector because actually it was far more lucrative to just keep dispensing prescriptions. Now, this was a fair number of years ago, but if you think about it, that's really a very, very concerning kind of statement. Instead, she's become this very, very positive force within our system, helping veterans to figure out how, working with their clinicians as partners, they can actually get to a better place, hopefully without opioids, but at a minimum on a much lower dose than they've been on in the past. So I'll stop there, and thank you for the opportunity.
Good afternoon, everyone, or I guess good morning. My name is Christine Gertz. I'm at Palmer College of Chiropractic. I want to thank Gallup for organizing this event and all of the speakers. I've learned something new from every single one of them in a field that I actually feel like I know quite well. So based on the presentations we've heard in the room today, there seems to be a growing sense that an important way to address the opioid epidemic is to put conservative, patient-centered, drug-free pain management at the forefront of the patient experience. Recently, several colleagues and I published a paper in the Spine Journal outlining an approach to do just that, an approach that we are calling the primary spine practitioner model. I'm using a slide because I'm going to be going through something fairly complex really quickly, and sometimes it helps to have a visual. So in this model, healthcare systems, including patient-centered medical homes and accountable care organizations, would, at the very beginning, triage patients with low back pain, neck pain, and other spine-related conditions to the primary spine practitioner. Examples of those who might serve in the primary spine practitioner role include doctors of chiropractic and doctoral level trained physical therapists. It's important to note that these clinicians are already in the healthcare workforce, that they already have specific expertise in the treatment of spine-related conditions, that they're already state licensed to use non-drug therapies. In fact, by their scope of practice, are not able to prescribe medications. And contrary to Carolyn's comment about acupuncturists, there may actually be a chiropractor on every corner. To give you an idea of how all this might work, a patient with low back pain would call their healthcare clinic and tell a person that they needed an appointment. A triage nurse would then schedule the patient for a visit with a primary spine practitioner. At that first visit, the primary spine practitioner would do a patient history, perform an examination, and then arrive at a diagnosis. Based on that diagnosis, on any comorbidities that might exist, and patient preferences, the primary spine practitioner would then either manage that patient's care autonomously, working within his or her scope of practice to deliver some of the non-drug therapies that Dr. Carroll mentioned earlier, such as spinal manipulation or acupuncture or education on exercise, or they would refer that patient or manage that patient's care within either a co-located or a virtual multidisciplinary team. And members of that team might include, depending on the patient's condition, primary care doctors, specialty care physicians such as orthopedists or neurologists, may include mental health professionals, may even include spine surgeons. We believe that the primary spine practitioner model has the opportunity to impact the healthcare system in a couple of important ways. The first is by improving the value of spine care delivery. Dr. Carroll talked earlier about the evidence base for a number of non-drug therapies, the majority of which are commonly used or recommended by primary spine practitioners. He also noted that these treatments result in lower overall costs to patients and have a lower risk of harms. Adding to the value equation is the fact that these therapies are inherently patient-centered. Could I have my next slide, please? Dr. Carroll talked about the role that measurement of patient satisfaction may have had in contributing to the opioid crisis. Work at the Palmer Center for Chiropractic Research has found that, as shown in this slide, when patients are randomized to receive either medical care alone or medical care plus chiropractic care, those who are seeing the doctor of chiropractic are more likely to experience significant increases in patient satisfaction, as well as perceived global improvement at the end of their treatment period. Thank you. I'm done with my slides then. The second potential impact that the primary spine practitioner model might have on the healthcare system is in regards to having a role in addressing the primary care shortage. Just imagine if every single patient that had low back pain, which is one of the most common reasons that people visit primary care physicians, instead went to a primary spine practitioner. This would free up time for primary care physicians to spend with patients who are much more likely to respond favorably to pharmaceutical management, patients that have diabetes, patients that have cardiovascular disease. While there are compelling reasons to consider adoption of the primary spine practitioner model, clearly there are significant barriers that exist. For one thing, it's been my experience that payers, policymakers, purchasers, primary care physicians share perceived and real concerns regarding the quality and consistency of the care that's delivered by some who would be acting in the primary spine practitioner role. Ways to address this barrier include commitments on the part of primary spine practitioners to engage in evidence-based clinical practice, to contribute to clinical data registries, and to to engage in performance improvement initiatives at a national level, such as the Medicare quality payment policy reform and the Choosing Wisely campaign. Further, mechanisms that facilitate collaborations across professions could be implemented by health systems. These include multidisciplinary efforts to jointly develop evidence-based clinical practices that incorporate the primary spine practitioner model, but also make sure that appropriate referral mechanisms are in place. A second barrier is illustrated by the Gallup data we saw today. There appears to be somewhat of a disconnect between the treatments that patients feel or that consumers feel are safest and most effective and the types of clinicians that they would like to see first. Obviously, changes in insurance payment strategies could help address this barrier, but so could patient education materials, encouraging the use of non-drug therapies, but that include evaluation and a trial of treatment by a primary spine practitioner first, before considering other less conservative options. In summary, the primary spine practitioner model has the potential to make important inroads in improving patient care for those suffering from spine-related conditions such as low back pain and neck pain. This is an area of healthcare delivery that, as we've seen today, is desperately in need of innovative solutions. Further, it's consistent with the American College of Physicians guideline on low back pain that came out recently, and it's consistent with consumer preferences for the treatment of low back and neck pain that we saw today. As Dr. Carroll was talking, I wrote down, low back pain does not kill you. However, the treatments might. Speaking not only as a scientist, but also as a person who's had chronic low back pain for about 30 years, I believe that the healthcare system in the United States has the capacity to do much better than we are right now when it comes to treatment of spine-related conditions. Thanks to Gallup and to all of our speakers today for facilitating a discussion on exactly how we might begin to approach this issue. Thank you.
And I'm sure that you guys have lots of questions, and while you prepare and think about them, I'm going to ask one quick one, and I'm going to ask mostly for a reasonably quick response because then we can get to audience questions. But I'm struck that while all of you were talking about, or most of you were talking about things that we can do and things that would give me lots of optimism, and as a researcher warm my heart with the idea of we're going to do this pragmatic trial. A lot of those solutions seem like something I will read about and perhaps write about in 5 years or more. We keep talking about this is a crisis, this is a national emergency. So I wanted to just sort of ask all of you, what do you think we need to do right now? What would be the best thing that we could do today, or at least let's say in the next few weeks, in order to try to make this entire problem better?
I'd have to think about that a little longer, but I would say that just what we're doing today, what you're doing, Aaron, what Palmer College is doing, talking about this, even talking about the research that we're doing, draws attention to the fact that there are options. There, you pointed. I mean, we may not know exactly what works best for whom, but there's a lot of evidence that there are a lot of alternatives. I mean, I've heightened my awareness of how many options there are. I've heard primary care doctors talk very constructively about programs of getting patients aware of a multitude of treatments. So I think actually, and you made this point, we're sitting on a lot of evidence. It's even been synthesized. What's needed there is disseminating that. Yes, more research is needed, but there are a lot of things getting started. I mean, I think the fact that you're seeing the levels of use, the levels of prescription beginning to drop for the last number of years, I guess, is evidence that I'm kind of right, that talking about it is important even before the final results are in.
Great.
Yeah, I would echo much of what Joe said. There is research out there to show where these complementary integrative health approaches can be effective. I think also, but certainly more research is needed, and I would say that the pragmatic trials are absolutely necessary to optimize delivery, to know how best to serve the patient. But, and I think you touched on this, Dr. Carroll, when you talked about risk-benefit, these approaches are relatively safe. Across the board, many of them are self-help practices. If you're talking about contemplative practices such as meditation, when you're talking about cognitive behavioral therapies, that's a strategy that patients practice. These are relatively safe interventions compared to the alternatives. So I think the research needs to happen because we need to know more about how best to deliver care for these approaches. But I think if I had a chronic pain condition, I would try some of these safer approaches before thinking about the more risky alternatives. And I think anybody could do that now with the research we have.
So I think one thing we can do right now, and we're starting to do this, is to turn off the knee-jerk initiation of opioids. Having taken a relative in for an outpatient surgical procedure not too long ago, I won't say security needed to be engaged before we left without an opioid, but we were getting close to that point because there was sort of a standing protocol that you give the patient a dose of pain medicine before they're discharged. It took a lot of oomph. The second point I would make is that this is, particularly the results of this survey, I think are a command for clinicians and patients to have a truly informed conversation about this. We require informed consent across our system, but I think we need to take that in its fullest possible meaning, and that ought to be the new normal everywhere. The third is that we shouldn't leave empathy out of this equation. Chronic pain can do a number on your head. An older relative recently had a very severe fracture and fortunately is doing much, much better now. But I was very struck because I asked my sister how she was doing. She went to visit her and she said, oh, you know, she's doing well and physical therapy is going slow, but she's progressing. She said, but the whole time I was talking to her, I could tell all she was thinking about was how much pain she was in. And I thought, boy, that really, really distills the essence of the challenge that we're trying to solve. So these solutions, particularly non-pharmacologic, are not instantaneous. It's not like you're better in an hour, but they do give you far, far few side effects and give you the option as an individual to take much more of a role in managing your own destiny. Mm-hmm.
As a scientist, and especially with NIH in the room, I'm going to, of course, say that we need more research. But while we wait for that research, I agree with my fellow panelists that I think we have enough information, we have enough of an evidence base to start incorporating some of these treatments right now in a much more meaningful way. And so from my perspective, the first thing to do would be to start discussing how we can institute system change. How can we provide and how can we encourage healthcare systems to consider some of the treatments that we've discussed as the first line of defense? I'm really excited at the steps that the VA has taken to move in this direction. I think that they're providing a model that other health systems could adapt as well.
Yeah.
Do we have questions from the audience?
Good morning. My name is Liz Mattori. I'm with the Ridley Group. I'm actually coming as a criminal justice advocate and a chemically dependent advocate person. My parents are also physicians. They worked with the National Medical Association for 40 years. And I also, a lot of friends who are veterans. A couple things. One, a lot of patients feel as if, doctor knows best, and they don't have this sense of personal autonomy. What do you have to say to that, especially the gentleman about the patient-centered piece? And secondarily, why aren't we doing more about medical cannabis? I know a lot of people have a huge stigma attached to herbals. But I just lost a friend to an overdose last year, Christopher Berry, and it's getting so personal that it's getting ridiculous that we're not even able to research the research. So I just want to know, I know that legally you might not be able to speak on the reality, but I just wanted to ask a question.
Well, I'll tackle the first part of it, the part about doctor knows best. I think you're right that there are still a portion of patients in this country who think that, but I think that the numbers of patients and the numbers of doctors who believe it are shrinking. So our strategy is to get patients involved. I think a little whiff of involvement maybe scares people when they realize how quickly they realize that maybe doctors really don't know best. I mean, there's just a whole lot of medical practice where nobody knows best, and that's part of the reason we're here. But I think that needs to be combated. I think also we need to find ways to support communication. So shared decision-making tools sometimes come in handy, especially if they're tailored for different patient groups. So again, one size doesn't fit all. But most patients, when exposed to a little bit of responsibility for decision-making, take to it pretty darn well. I agree, though, with you that it has been a stance that people have adopted for the last, goodness knows how long, that doctor knows best. I think its demise is imminent.
Yeah, I think that the climate is changing again around patient-centered care. And I know from a perspective of our institute, the National Center for Complementary Integrative Health, we have a wealth of information available to patients, to the public, to allow them to make informed decisions based on the research we have. So, and much of our research is based on patient-centered care, the idea that the patient is involved in the care with healthcare professionals in determining the best treatment and the best approach for them. So that is part of the research, and how best to deliver and how best to inform the public and change the sort of the attitudes that exist currently is where the research can really help here. Your question about cannabinoids is a good one. About a year ago, the NIH put on what we call the Marijuana Summit, or the Cannabinoid Summit, that really started to look at where we are with cannabinoid research broadly. One aspect was of course, in research around treating pain and chronic pain, but other conditions such as PTSD, epilepsy, and so forth. We are very much, I will say, as an NIH, and I will speak for NCCIH, very much interested in looking at cannabinoids. It's a natural product, and about half our research portfolio is in the study of natural products. But you are correct, there are challenges out there in how to do it given the regulatory climate, but we are moving forward with research in this area. We actually funded a study at the University of Colorado to look at cannabinoids in the context of chronic pain. And we'll see how that goes, but this is the kind of research we need to do, and we'll continue to help and try to support moving forward.
Yeah, the one point I would just add to what my colleagues had to say, who said it very well, you don't want to just essentially say to the public, doctors don't know anything, or chiropractors, or whomever, right? When you have an acute life-threatening illness, I hope the doctor knows best, because, you know, I'm not going to be in a position to actually be in there as a co-pilot, but I would say for almost any chronic condition, an involved patient is a requirement to do well. Some docs manage this co-production better than others, but I think, as Dr. Selby said, that's diminishing over time and is a good thing. And frankly, patients will be better off for it, because there's a whole lot that goes on managing chronic conditions that doesn't take place in these intermittent encounters. And so it really, really behooves people to be very attuned to that.
Do you want to add anything, Christine? Or?
Just that I agree with what the other panelists said. I think that there is definitely a movement towards the patient as part of a decision-making process relative to their care. But I mean, to a certain extent, those changes really need to start being integrated within the medical school curricula, and for people to be taught those, because even though there is a lot of talk, my own patient experiences or being with members of families are still that it's pretty much top down, and an expectation that the patient will just more or less blindly do whatever the physician is suggesting.
Question all the way in the back.
Hi, good morning. Thank you for all of your contributions. It's very touching to me that you would contribute so much time to this, because I think it is a very significant problem, and it doesn't just affect the patient, it affects their families as well. I'm an occupational therapist, acupuncturist, and massage therapist. I practice in Annapolis. And my question comes out of the experience that my patients reflect back to me. It's not actually that physicians are not suggesting alternatives. it's access, and it's not access to practitioners. It's more access to payers. And I guess with you all up there representing your individual foundations and colleges and programs, I'm questioning what is Medicare's participation in this crisis management, as you guys are willing to give. As it is right now, as an acupuncturist, if I include acupuncture as even part of a treatment of a Medicare patient, that's illegal wherever I practice in the United States. So thank you for that, and just interested in your response to that. Thanks.
I don't think it's just a Medicare problem. I think it's just a payer problem in general. Part of the issue is that, even when I was talking about access, that insurance does not cover a lot of this. As a physician, if I write a prescription for an opioid, I know it's going to get paid. If I even write a prescription for many of my patients, even for an ENS, the Tylenol, ibuprofen, it's going to get paid. If I said, apply heat, no one's going to get paid to buy a heating pad. If I said, go get massage therapy, I'm not positive that would be covered. Acupuncture, I'm almost guaranteed would not. And so part of the issue gets down to we don't cover this even if people do have insurance. Some of the issue is, and this is where I'm torn, because in my perfect world, which is why I'm about to never be elected to office ever, we should never pay for anything that we haven't proven to work. I don't understand why we pay for so many things that have been proven in randomized controlled trials not to work. We continue to pay for it today. But I think that applies to both sides, though. And I've written about alternative therapy, complementary medicine versus what we would call traditional medicine. And I would love for it to be much more proven versus not proven than to try to come up with these other labels. But we don't pay for some things which we have proven to work, and we pay for many things which have been proven not to work. And it's a broken system. I don't know that Medicare is more to blame than private insurance is. The entire sort of reimbursement system is not properly aligned to drive people to proven therapy. But it is certainly, I think, part of the problem here. And when I was asking people what their immediate solution was, this is probably where I might point, is that I don't think we drive people, I don't think the financial drivers push people into what we would think are the optimal pathways for treatment. That they are still set up, even with the best of intentions, to drive people into traditional medical surgery, drugs, things that doctors and hospitals would do. And that fixing that or trying to change that might be the thing that would result in an immediate return. And I should say I'm speaking for myself, not for my university and not for anyone else. Even though you said I'm representing them, I am not. But I agree with you. I think that the access problem is major.
But I would also say that there's a very tight link, sort of chicken and egg, with the research and effectiveness issue. So historically, Medicare didn't pay for diabetic teaching for a really, really long time. They do, and then they ran into a problem with capacity as well as, I think, interest among providers. I was told informally, not officially, that some years they didn't spend all the money they had set aside for this program. Thankfully, that has expanded a great deal. So I'm not without hope, because one of the little challenges we've had is actually being able to code and therefore accurately link treatments to outcomes for complementary and integrative interventions. We're building that capability at VA, so I'm actually optimistic that we're not that far away from being able to say, gosh, if you invest in this kind of treatment, downstream you're going to see lots of important changes. And that's true of many, many interventions in healthcare. We don't have that kind of evidence which would be scored in policy terms.
If I could just add to that a little bit. I don't know if there are any payers, commercial or Medicare, Medicaid representatives in the room, but I used to work, like Carolyn, who is at the VA now, which is a payer as well as a provider. I used to work at Kaiser Permanente, and a payer's point of view, I have to sympathize with them to the extent that they see tsunamis everywhere. That if a particular new treatment is covered for the first time, that they will be inundated, flooded, overwhelmed by new costs, that won't necessarily offset old costs, and the whole expenditure just goes up. So I think, I mean, this may be a little bit optimistic, but I think that research can help understand who actually benefits, so you know who benefits, what the right doses are. I mean, does massage therapy make sense to continue for years, or is 6 months, after 6 months do you get any benefit? So more detailed evidence on what works, I think, can sometimes give payers the nerve to jump into a new area.
And I think that's where the NIH comes in here to provide that evidence base. And certainly we look to our research to the policymakers and clinicians to take that research and use it in a way that's helpful to policy change and practice.
I'm a little bit less sympathetic to the payer community than Joe is. When I talked about system change earlier, obviously changes in payment policy would really need to be a big part of that to substantially move the needle. And from my perspective, currently right now there's an unacceptably long gap between what the evidence shows might be most effective and what the payer community is actually providing reimbursement for. I think that's an area where there's room for improvement. I definitely see movement in the right direction, but it's something that all of us need to continue to talk about and be vigilant.
Hi, good morning. Thanks very much. I'm Joan Walter. I work for the Samueli Integrative Health Programs. And I actually started out with a multi-part question that was very similar to Dr. Carroll's question, although I characterized it slightly differently. We've covered some of it, but I wanted to ask what you see as the most important changes that could be made in government at the federal, state, and local levels. I think we've talked a little bit about that, and probably you're at the limits of what you can say. What are the most important industry or payer changes? We've talked about that, so I'm going to focus on, are there ways to develop public-private partnerships that would enhance or accelerate this discussion and the research and increase the impact and uptake of the research findings that you're seeking?
I'll take a stab at that. I'm sure many of us would. One of the things that excites me the most is when I see a room that has payers and clinicians and patients sitting down together. And we like to start it off by reminding them that they're at the Patient-Centered Outcomes Research Institute, and therefore this meeting is about meeting patients' needs. So I think in terms of public-private partnerships, or another one would be a public-commercial insurance partnership, and picking up on what we just said before, one of the views of what is pragmatic research to us is that the people, the decision makers that need this information have to be involved, so that at the end of the study, if the findings deserve it, they participate in implementing it. So in terms of the role of payers that Christine pointed out, participation with specialty organizations and with patient organizations in a research study with an understanding of how findings, if they merit it, could be implemented, that is covered, is a very good way to make the research really ultimately pragmatic. So that would be my nomination, to get the payers involved earlier in the research so that you can understand their anxieties and do a study that will change their practice and coverage.
Just to follow up on that, the NIH has the National Healthcare Collaboratory Project, which is a common fund, NIH common fund project, but that really is working with the private sector, healthcare delivery systems, overlaying pragmatic research again onto the healthcare system in real time, in a real way. And what we're seeming to find is that while the research in the long run may change practice overall, the research that's going on within the healthcare system is changing based on the outcomes of these trials. So here's a case where including the healthcare system and a research community working hand in hand to address real world problems in real time is having an immediate impact on healthcare.
Patients often describe that they're in pain, and their depression may result from pain, and the pain may actually be physical, where the pain is coming from an injury, or it's pain receptors in the brain that can't stop firing, and that the QEEG-guided transcranial magnetic stimulation has been effective for pain. I'm wondering about what kind of research you all might have done or are considering to do as that, in that regard. And also to make a comment that when my daughter was 16, she went to go get her wisdom teeth removed, and I went to a holistic dental surgeon, and he prescribed her opioids as the pain reliever post-surgery. And I just recall, having my wisdom teeth taken out, and other people, that no one was ever prescribed opioids for that type of transient pain relief. And wondered, where is the pressure coming from the medical community not to prescribe these terribly strong prescription drugs that could, as you said, cause other, health problems worse than the original pain that you'd be dealing with?
Well, I could take the first question about the transcranial stimulation. So the NIH has a very large investment in the Brain Initiative. You may have heard about it. It's a multi-year, decade-long program to try to understand the brain. And part of that is to develop new technologies to modulate and record from the brain. And certainly transcranial, non-invasive transcranial stimulation is an active area of research in that program, and NCCIH is part of that program. And I wanted to comment too on the point you made, that I agree with you that pain patients generally have, and Dr. Carroll mentioned this, comorbid conditions. And a common comorbid condition for pain patients is depression and the rumination that goes along with being in a chronic pain state. And I think exploring some of these non-invasive approaches, non-pharmacological approaches, such as non-invasive brain stimulation, is clearly an area that is really ripe for additional research and additional support. And that is an area that NIH is, in fact, doing more research on. So I think in the next several years, we'll start to see and think about not only where the stimulation is effective and for what conditions, but really what the part of the Pain Initiative is to optimize the technology and get a better understanding of the mechanism by which giving a magnetic stimulation or a direct current stimulation to the brain is actually changing the brain. How is it changing it? Why is the brain changing? And how is that improving outcome?
I would just add that that's very exciting to me, and I would say that once NIH gets a little bit more of a handle on the mechanisms and the fact that it does work, PCORI would be very interested in proposals for pragmatic studies in that area, for real-world studies.
Yeah, we also just launched a trial looking at non-invasive electrical brain stimulation to treat osteoarthritis knee pain, which is very, very common as people get older, probably starting at a younger age than in the past. Whether that's due to lots of working out, I haven't figured out. But if you think about it, it's incredibly exciting. And this was something that was observed when the same technique was being used primarily for a neurological issue. They noticed that people had a lot less knee pain after a couple of treatments, which lasted for a few weeks. So there's clearly something going on there, and I think it's going to challenge the scientific community to be able to articulate mechanisms that are very different than what we've seen and what we were all trained in terms of pathophysiology and so forth. But it's exciting.
Question over here.
Hi, my name is Dylan Landers Nelson. I work with the National Business Group on Health, so it's a member association of large self-insured employers. And so just thinking about some of the comments about the payer community, we definitely find that being able to put evidence in front of health benefit managers who, particularly at large employers, have some more leeway to get creative about how they put together benefits is helpful. So we work with Joe at PCORI and several folks from ARC and others who are creating comparative effectiveness research, and certainly Dr. Carroll, appreciate your easy to read comparative effectiveness reviews and write-ups. I think something that the evidence creators and aggregators could do better is not putting out 500-page reports that are impossible for average people to understand, and particularly benefit managers and others who are professionally using this research but might not have the time or the resources or even the wherewithal to fully understand it. I think, I'm sorry, I'm rambling here a little bit, but Dr. Carroll, you made the point about covering things that have evidence and not covering other things that don't have evidence. And one of the things that employers run into is that there's a certain risk tolerance that they have. And so some things that might be a little bit more out there, like not covering some things that are standard medical practice, even if they don't have a lot of evidence, can really, for lack of a better term, kind of piss off your employees, or you might cover some things that don't have a lot of evidence base because you're a tech company and you have piles of cash and you're going to cover things because you want to attract people to come work for you. So there's a lot of complications, but we're putting evidence in front of our members to try to say cover these alternatives to opioids because there is some evidence that they work and you want to avoid putting people on drugs unnecessarily. So to get to a question, Dr. Carroll, you mentioned earlier that there's limits on covering medication-assisted therapies or treatments, kind of federal policy related, and that if everybody prescribed these treatments as much as they could, we would only cover half of people who could actually benefit from them. Is that within the bounds of those federal limits?
Yes, that's just buprenorphine. That's just how we regulate buprenorphine. So it just as an example, sort of the capacity for using buprenorphine, I have to say that word enough times I'm going to screw it up, but it's the capacity for like how much we could use that as one of the accepted is already limited just based upon the number of physicians that are willing to do it and the guidelines and how often. Those regulations don't necessarily apply to naltrexone. Methadone is a whole other can of worms, but doesn't have the same type of regulations. The problem is that one is it's still a safety issue where many people are worried about it, but two, there is still a taint. People still view the use of methadone as I'm just substituting one drug for another. Sure. There are, without mentioning names, politicians who are very anti-naloxone, or the use of medications to help people in terms of an overdose or a crisis. And still, those barriers at a policy level still prevent widespread use of sort of medication-assisted therapy. But there are all the other issues as well. But certainly those are the policy issues I was pointing to. I think I'm being creeped up, but I think we've unfortunately reached our time limit. So we're just going to transition back here. But let me personally say thank you to all the panel. I'm sure they're going to thank as well. But thank you very much for everybody who participated today. We really appreciate it.
I was going to say from the whole Gallup tribe, thank you to the panel, but more specifically, thank you to you, Aaron, for being our host and for such a wonderful presentation earlier today. So thank you for that. Just three other things. I also wanted to especially thank Christine. We have a very important partnership with Palmer, and I want you all to mark your calendars for October 3rd, because on that day, Gallup and Palmer will come out with its official report on Gallup.com. So we highly encourage you to download that report as soon as it comes out. And the last thing to keep in mind is the report that you have at your desks, the report on how Americans feel about the opioid epidemic and opioids in general is now available live on Gallup.com. Thank you again to all of our panelists, and thank you, as always, for joining us here at Gallup. We're adjourned.